Good morning, everyone, and thanks the organizers for the invitation to talk in the symposium, and thanks everyone for waking up so early. So today we'll talk about learning from neuroimage data, for neuroimage and clinical data, a multi-source machine learning approach for mental health disorders. Well, it's not. I've seen this before, but it didn't work. It didn't happen with me. Now it's. So the focus of my talk today will be on how can we use machine learning techniques to find predicted patterns from psychiatric neuroimage data, which I think most of you will agree with me that, well, this is going to be, okay. It's not working. Okay, it's rich, complex, and messy. So I hope, is it working or not? Because I think you were passing the slides. I'm not controlling, it just doesn't respond. I don't think it's working. And I'm pretty sure I'm pressing the right button. It doesn't. Yeah, sorry, I don't know. Should I? It's a bit tricky to continue about, because I have a couple of animations through the talk. It doesn't respond. It doesn't respond, so you can, Is it now? Now it's working. Apparently it's working. So, well, I'll start just again for people who are coming. So my focus of the talk today will be on how can we use machine learning techniques to learn predictive patterns from psychiatric neuroimage data, which I think most of us will agree it's rich, complex, and messy. And in terms of machine learning techniques or machine learning frameworks, so far, the most applied framework to neuroimage data analysis or clinical neuroimage data analysis has been the supervised framework with the goal of building neuroimage-based classifiers. And here I just have the idea behind it. It's quite very standard. The goal is to find a classifier that could make diagnosis and prognosis. So we train the classifiers with brain scans from a group of healthy people and a group of patients. And the goal is that, during the training, the machine learning algorithm will find this distributed pattern in this neuroimage data that can help us to distinguish these two groups. And once we find this pattern as a predictive function, we can use it to make predictions for new data. And this framework has been applied to address a number of clinical questions in psychiatry, in particular over the last 10 years, such as diagnosing across diseases, predicting disease outcome, identifying at-risk subjects, and identifying treatment responders. And there has been, I think, hundreds or thousands of studies addressing these questions. And I think they really show a strong evidence that there is predictive information in neuroimage data that can be used for psychiatry, diagnosis and prognosis. But they have been also subject to some criticism. And I think the biggest one has been in terms of replicability, particularly when the sample size gets bigger. So I think that there are many reasons for this lack of reproducibility, but today I will focus on one that I think is related to the limitation of the framework we have been using. Basically, in my view, the biggest limitation is the fact that a clinician, when makes an assessment and a decision about the patient diagnosis, is quite rich information that is collected. And we summarize all this information in a single categorical classification, which is the label used to train these machine learning algorithms. And we know, and there is a lot of evidence, that the categories in psychiatry are very unreliable. So the boundary of these categories don't align with findings from neuroscience, genetics, and they have not been predictive of treatment response as well. So basically, when we use these labels, our assumption is that the patients are coming from an homogeneous distribution, and the patients are coming from another homogeneous distribution, and we try to find a boundary between them. but the real world is much more like that. There is a lot of heterogeneity in the patient group and in the health controls, particularly for big samples. So we need to find other ways of modeling the data without having to rely on this categorical classification. And I will just show a few examples through the talk today. How can we move away from the categorical classification and still use machine learning to learn from something from this neuroimaging data? One way that we can do that, is with regression models. So it's a quite simple approach. Basically, it's the same framework, but we can treat the problem in a continuous way here. So we are interested in finding this relationship between brain scans and some labels, but here just the labels are continuous measures, can be clinical symptoms, for example. And we have these two phases. We train the predict function, and you can make predictions, but just treating the problem in a continuous way. And this framework has also been applied a number of times to address questions in psychiatry, such as predicting symptoms from brain scans and predicting also personality traits from brain scans. And I just show an example from the work in my group where we did recently, we applied this framework to investigate if we could predict a clinical symptom from a sample that have different diagnoses. So basically, in this specific study, we had a group of youth, and they had different diagnoses, different psychiatric diagnoses, but what they had in common was that all of them had some level of emotional and behavioral dysregulation. So, and what we had for each subject here was, it was an fMRI study, and we had a pattern of brain activations during a reward task. And our question is, can we predict these clinical symptoms regardless of their, the fact that they have different diagnoses in the group? So as a proof of concept, actually, we could predict, a measure that is called Parent General Behavior Inventory is a measure that captures the emotional and behavioral dysregulations in this youth. And we are able to make predictions, to predict this significantly, despite the fact that the group had different diagnoses. So I think that's one example. How can we move away from this categorical classification and still learn some predictive patterns from this data? Another way that we can also approach this problem is with normative models. Trying to build normative models for neuroimaging data. And actually, normative models is something quite common in medical areas. When we do a blood test, our measure will be considered abnormal with respect to normative models. But normative models become a bit more complicated when we have high-dimensional data. The idea in normative models is, again, we train the model with the data. We're trying to find a predictive model. But here we don't need to give the labels. We just train the model with health people, for example. And the goal would be, once we have these normative models, it works as an outlier detection. And then in a perspective of machine learning, and the idea is that once we have a patient, we want to see that the patient is outlier with respect to this normative model. And this approach has also already been applied to address clinical questions in psychiatry, as I just mentioned, to see if patients can be considered as outliers with respect to a normative base of controls. So I just show out again another very short example of this application that we did a couple of years ago. So here we try to test the hypothesis if we could treat the patient classification as an outlier detection problem. And in this study, what we had is we had a group of patients with depression and a group of healthy controls. And for each subject, we had, it was an fMRI study, and then we had the patterns of brain activations to SAD phase. So what we did is that we trained an outlier detection algorithm called one-class SVM with the data from the healthy controls, and then we tested with some test health controls and some depressed patients. And what we found was that from the healthy controls, 79% were classified as no outliers. What we thought, okay, that's a good result. But then when we look at the patients, only about 50% were classified as outlier. And what we initially thought was a bad result, because detecting just half of the patient is not a good result in terms of prediction, but these patients had some follow-up information. So some of them had responded to a treatment and others not. So when we look at this follow-up information, we found that 70% of the responders were non-outliers, and 89% of the non-responders were outliers. So what the data was showing what it was for us was that the real outliers were the non-responders patients, which we thought was a very interesting result. Another outcome we have from this approach is how outlier a subject is. So when we correlated this measure with the depression score, we found a very high and significant correlation, showing that the more depressed the subjects were, the more outlier they were. So this is just another example how we can still learn something from neuroimage data without having to rely on the categorical classification. And I think these two examples I showed are just good examples of how you can do that. But in a way, they are still limited because, in both cases, they rely on one single neuroimage modality, and they still rely on one measure, like being or no outlier, or a continuous measure in case of regression. And one question we have now in the group is why not add more information into these models? And actually, often, in particular now in time of big data, a lot of information is collected from patients and also from healthy control. So we have multiple modalities of images, and we have behavioral, clinical, demographic information. So I think the way to move forwards is really incorporate as much as information as possible into the models. And we can do that using multiple source learning or multi-view learning in a machine learning perspective. And so the idea is to combine multiple modalities of imaging with additional information that can be behavioral, clinical, genetics, and we can combine this different source of information with two goals. One goal is to build multiple source or multi-view predictive models for diagnosis and prognosis. And the other is to build multiple source models for stratification. And I will try to show the next two slides, the differences between these two goals. The first one is exactly what I already described before, the idea of combining these multiple sources of information for prediction. So the difference here is that we are giving multiple image modalities as input to the model, and you want to learn the relationship considering, between all these modalities of image and a certain score, and we can, once we train the model, we can make predictions. And we can extend that model actually to have more than one score, and there are a number of machine learning algorithms that can do that, such as, multi-output learning. And so you don't need to restrict yourself to have trying to predict one single measure. And there is now evidence that actually trying to predict more than one might be more efficient, and you might get better results because you capture the relationship between them during the training. But I will focus on the second goal, which I think, that multiple source models for stratification, which I think can be much more transformative for mental health disorders and psychiatry. The idea here is still to combine the different source of information, but here we are including also the clinical and behavioral information as input to the machine learning algorithm. And the goal is that we use algorithms that will find common patterns across these different sources of information that will enable us to find groups of subjects. And the hypothesis is that, the groups of subjects that have common patterns across the different modalities might correspond to more homogeneous groups of subjects or group of patients that might be more likely to respond to a specific treatment, or might correspond to groups of subjects that are at risk of developing some diseases. And I will just show an example of how we have been approaching this problem recently. The way we approach this, because it's quite high dimensional if you think here, with all this data, which individually is already high dimensional. So basically what we have been doing is we have been trying to learn a brain behavior latent space. The type of modeling that we use for that is models that capture a relationship between two or more multivariate data. And one example of this is the sparse partialist square, but there are other examples of approaches that do that, such as canonical correlation analysis as well. But so the idea here is to use the models that capture associations between this multivariate data set. And the way these models work is that they find pairs of weight, one for each source of data, here the brain and the behavior, such that in case of the PLS, we maximize the covariance of the projected data. But basically, these weights capture the multivariate associations between this different source of information. And because we are here using a sparse approach, we can identify a subset of brain features that are associated with a subset of behavioral features. What we can do then, we can project the brain data onto the brain weights to compute for each subject brain scores, and we can do the same with the behavioral data to compute behavior scores. And what these scores tell us is how much a specific subject is expressing this association. Then, once we have these scores for all the subjects in our sample, we can then plot this information in a brain behavioral latent space. And we can see how this association, this multivariate association is varying across our sample. The hypothesis is that actually this space might be more informative for us to identify subgroups of subjects instead of just using the original space of the data. And I will just show an example of how you use this as a proof of concept. We apply this framework as a proof of concept to find brain behavior associations in the ADNI sample. I think most of you might be familiar here. It's a big data set, public available, that has brain image and behavior from demented patients and healthy controls and MCI, mild cognitive impairment patients. So here we use the sparse PLS to find associations between structure, MRI, and 30 items from the MMSE score, which is the mini-mental state examination, which is a quite common questionnaire that is used to assess dementia. So what we found is we found two multivariate associative effects. One, I don't know if you can see there, but the first one captured an associations between the amygdala and hippocampus and some items from this questionnaire that were related to memory. And for us, this was a very important proof of concept because the approach is completely data-driven. So we really found the associations from all voxels in the brain between the hippocampus and amygdala and the memory-related items. And we also found a second associative effect that was more spread through the brain and also more distributed, like in all items of the MMSE score. So then what we did was we computed these brain and behavior scores, and we could plot the sample here on this latent space. And what we can see here, we have two on the left side. We can see that this space really for the brain score captures some progression of the disorder. You can see here that in red we have the demented, green MCIs, and healthy in blue. And the more demented the subjects were, so the lower score they had for the first associative effect, and the higher score they had for the second associative effect. And we can there is no clear separation here because we are using the categorical classifications as a color code, which has all the issues I stated in the beginning. But the idea is that this is really capturing some progression of the disease. We cannot see the same with the clinical scores, but we can still see some separations between the demented and the other two groups. And this is just to illustrate how we can use this approach to learn something about the data by combining multiple sources of information. And I'm running out of time, so I'll just acknowledge my group who has been helping with all this work and my colleagues and collaborators.